important to cardiac surgeon before, during, and after the operation. 4 cardiac surgeons and 1 cardiologist, 2 infectious disease specialists were involved in the writing committees, and 4 cardiac surgeons, 1 anesthesiologist, 1 cardiologist, 2 imaging experts, and 3 infectious disease specialists with a neurologist were invited as a reviewing committee. So, following the recommendation of the Institute of Medicine's 2011 clinical practice guidelines, we can trust standard for developing trustworthy clinical practice guidelines, and using the standard classification of recommendation and level of evidence. The recommendations were made based on reviewing the literature and grading the quality of evidence supporting the recommendations, and assessing the risk-benefit profile for each recommendation. These are some abbreviations that were used, and these 3, the infective endocarditis, native valve endocarditis, and prosthetic valve endocarditis are quite common in our talk today. Now we'll start with the recommendations one by one with some comment on each. Recommendations are divided into 5 categories. First one, the surgery for infective endocarditis, then pre-surgical, intraoperative, post-operative management, and the last is specific considerations. So, who should care and operate on a patient with infective endocarditis? Infective endocarditis patient should be treated by a specialized endocarditis team, including an expert cardiac surgeon. So, it's class 1 indicated that patient with suspected infective endocarditis should ideally be cared for at centers with access to complete team, including cardiology, infectious disease, cardiac surgery, and other services needed to handle any complication. Surgeons operating on patient with infective endocarditis should be well-trained, experienced valve surgeon who are well versed in the different reconstruction technique needed by patients with advanced disease. What does the surgeon need to know? Blood culture should be taken before starting antibiotic, and 3-dimensional TEE, transesophageal echo, for assessment of vegetation and complication like abscesses or perforations. So at the time of surgery, the patient should be on effective antimicrobial regimen, including the dose and route, according to the sensitivity. If the sensitivity are unknown, so the patient should be broadly covered by antibiotics. For surgery planning, the surgeon should have the best possible understanding of the pathology. This will usually require advanced imaging techniques such as TEE. Other imaging modalities may be appropriate in selected cases like MRI. What are the indications for surgery in patients with infective endocarditis? One half of patients develop severe complication like severe valve dysfunction, heart failure symptoms, invasion like abscess or manifested by abscesses or fistulas, and recurrent systemic embolization or large mobile vegetation, persistent sepsis despite treatment more than 5 to 7 days. What are the indication? This is the recommendation for the same question. This recommendation assuming operable patient and not contraindicated for heparin or cardiopulmonary bypass. There are around 6 indications for surgery. The first 4 are class 1 indication and states that surgery should be during initial hospitalization and regardless or independently to the completion of full antibiotic course. First one is for patient with with infective endocarditis who present with valve dysfunction resulting in symptoms for heart failure. The second one is for patient with left-sided infective endocarditis caused by Staph aureus fungal or Staph aureus or fungal or highly resistant microorganism. The third one is for patient with infective endocarditis that's complicated by heart block, annular or aortic abscesses, or destructive penetrating lesions. Fourth one is for patient with persistent infection that manifested by persistent bacteremia or fever lasting for 5 to 7 days after initiating appropriate antimicrobial therapy. So we'll continue with other indications for infective endocarditis. Surgery is recommended for patients with prosthetic valve endocarditis and relapsing infection that defines as recurrence of bacteremia after complete course of appropriate antibiotic and subsequently negative blood cultures without other identifiable source for portal of infection. And surgery during initial hospitalization, regardless to the completion of therapeutic course of antibiotic, is reasonable in patients with infective endocarditis who present with recurrent emboli and persistent vegetations despite starting appropriate antibiotic therapy. Urgent or even emergency surgery may be considered, that class 2B, in patients with native or prosthetic valve endocarditis who has mobile vegetations larger or greater than 10 millimeter in length with clinical evidence of embolic phenomena despite appropriate antimicrobial treatment. For right-side infective endocarditis, in addition to symptomatic severe valve dysfunction, surgery should be considered in patients with native valve or prosthetic valve endocarditis when large vegetations are present and there is evidence of persistent infection manifested by bacteremia or fever lasting for 5 to 7 days after appropriate antimicrobial therapy, or in those with evidence of septic pulmonary embolism. So either persistent large, so either patient with large vegetations and persistent infection, or patient with large vegetations and septic pulmonary embolism. When should the patient undergo for operation? Simply if he has an indication for surgery, or and he was started on antimicrobial therapy. So once an indication for surgery is established, it's class 1 indication that patient should be operated on within days. Earlier or emergency surgery, or earlier surgery like emergency or within 48 hours is reasonable in patient with large mobile vegetations who's at high risk for embolism. In patient with stroke or neurological deficit, timing is decided by weighing the need for cardiac surgery against the risk of expanding the stroke or provoke intracranial bleeding during the operation. So there is different recommendations are about the presence of vegetations, and it may cause some confusion. So I tried to collect these three together. Together. First of all, the risk of embolism is higher in the first 2 weeks of antimicrobial therapy. And the risk of embolism is related to the size and mobility of vegetation. So here, any patient with persistent vegetation, he has class 2A indication that he should have surgery during initial hospitalization, before or regardless to the completion of the therapy. But patient, if he have mobile vegetations greater than 10 millimeter with embolic phenomena that he has already established, or he embolized, that his urgent or emergency surgery is class 2B. But if the patient not embolized yet and he's on high risk for embolization, this will be class 2A. Now we'll start with pre-surgical management recommendations. What is the effect of neurological complication, embolic stroke, brain hemorrhage, and mycotic aneurysm on indication for and timing for surgery? Patient with neurological symptoms or complication should have neurologic evaluation and brain imaging, CT or MRI. This brain imaging should be or to be repeated if new symptoms. No surgery for patient with severe neurological deficit until recovery. The current recommendation is to delay the surgery for 1 to 2 weeks in non-hemorrhagic stroke and 3 to 4 weeks in hemorrhagic stroke. So about that recommendation says, if cerebral mycotic aneurysm has been diagnosed, treatment and follow-up of the patient should be in close collaboration with neurologic and neurosurgery expertise. And in patient with recurrent intracranial, in patient with recurrent intracranial hemorrhage, delay of operation for 3 or more weeks is reasonable. Earlier surgery is reasonable for patient with non-hemorrhagic stroke and strong cardiac indication for urgent surgery. Any patient with multiple stroke and severe neurologic symptoms should be carefully evaluated by neurologist before being offered surgery. And for patient with infective endocarditis, neurologic symptoms, and significant intracranial hemorrhage, Angiography should be considered to rule out mycotic aneurysm. Should all patients with infective endocarditis scheduled for surgery have preoperative brain imaging? It remains controversial, but one study showed that brain embolization has been detected by MRI in 70% of patients without neurological deficit or symptoms. Mortality was similar. Mortality is similar among symptomatic or asymptomatic stroke, but lower in those with a negative MRI. So endocarditis patient with neurological symptoms should have brain imaging. This is class 1 indication. And patient without symptoms and with left-sided infective endocarditis is class 2A. It's class 2A indication that he should be, that it's reasonable to be screened for stroke or intracranial hemorrhage, particularly if he's high risk for embolic events. So all patients should be examined for infected teeth. Other specific recommendation that the recommended investigations include colonoscopy for patient whose causative organism is Streptococcus galolyticus, or CT head, chest, and abdomen for patient with causative organism is Staph aureus or Aspergillus. So the recommendation says that patient with infective endocarditis should be screened for primary non-cardiac focus of infection, non-cardiac complication, and satellite infection. And the choice of the screening tools is, and the selection should be individualized for each patient based on clinical symptoms and suspicion. How should anticoagulation in patients with infective endocarditis with and without stroke or intracranial bleeding be managed? Infective endocarditis itself is not an indication for anticoagulation. So if patient has an indication for anticoagulation, so anticoagulation has to see compromise, taking all risk and benefits into consideration. And heparin should be used with cautiously in patient with infective endocarditis, particularly when there is evidence of brain hemorrhage, and be temporarily withheld in patient with higher risk of rebleed. What additional workup is needed before taking the patient for surgery? The risk of provoking an embolic stroke or compromising renal function should be considered in patient who's indicated for coronary angio. So as we said, as we read before, that brain imaging is reasonable for patient even without neurological symptoms. Regarding coronary angiography should be guided by normal criteria, but in patient with large aortic valve vegetations, CT angiography is an alternative to assess the coronary arteries. CT chest is recommended for patient who is going for reduced imaging. Is preoperative duration of antibiotic treatment is important? 1 week is enough to reach the lowest chance that you'll have positive culture from the valve. So the patient should be on an effective antimicrobial regimen at the time of surgery. And usually sensitivity and causative organism is known. Once the patient is on effective antimicrobial regimen, further delay is unlikely to be beneficial. What is the risk of operation for infective endocarditis? Many factors are affecting operative risk. Patient factors is comorbidities, disease is the stage and complication and acuity, surgeon experience. So the patient should be quoted risk taking into consideration all factors known as to affect the risk of operation. Now we'll go through intraoperative management recommendation. Initially, there are 3 points are recommended as class 1 indication, that the use of intraoperative TEE and median sternotomy. Medium sternotomy is the approach of choice, and radical debridement and removal of infected and necrotic tissue and foreign materials. These all are these three are all class 1 indication. So regarding the choice of reconstruction and valve replacement, general consideration and recommendation. For left side infective endocarditis, in general, repair is preferable over replacement if possible. And in simple valve replacement, no superiority of tissue over mechanical prosthesis, except to the avoidance of post-operative anticoagulation. If aortic annulus or root is needed, reconstruction or replacement, allograft is preferable over alternative conduits. And autologous pericardium proved superior additional material if needed. So, for patient with native valve infective endocarditis that's limited to valve clasp or leaflet, repair is performed whenever possible. And for simple valve replacement, when simple valve replacement is required, the choice of the valve mechanical or tissue should be based on normal criteria like age, life expectancy, and comorbidities, and expected compliance with anticoagulation. It's reasonable to avoid the use of mechanical prosthetic and prosthesis in patients with any intracranial bleeding or those who have suffered a major stroke. For patients with invasive disease and destruction, reconstruction should be depend on the involved valve, severity of the destruction, and the available option for cardiac reconstruction. Now we'll specify these recommendations to each valve. For aortic valve infective endocarditis, it's a native valve. So as we said, if infection is limited to valve clasp, repair may occasionally be possible. And the choice of the valve, mechanical or tissue, should be used on usual criteria. For invasive and destructive native aortic valve, for invasive and destructive native aortic valve endocarditis requiring root reconstruction and replacement, the use of allograft may be beneficial, but prosthetic bioroot or prosthetic valve conduit with mechanical or bioprosthetic are acceptable alternative. with the choice guided by surgeon training and experience. For prosthetic valve, if the annulus are preserved after radical debridement, it's reasonable to implant a new prosthetic valve, which is mechanical or tissue based on normal criteria. And if the annulus is, if there is any annulus destruction and invasion outside the aortic root, the reconstruction or replacement is required. So an allograft also, again, the allograft or biologic tissue root is preferable to prosthetic valve conduit. For mitral valve, also again, repair is preferred choice whenever possible, including the use of prosthetic annuloplasty ring when appropriate. And when there is valve replacement, when valve replacement is required, a prosthetic valve, either mechanical or tissue, is acceptable, unless there is risk of intracranial bleeding, in which case tissue is preferable. When there is annulus destruction and invasion, the mitral annulus is reconstructed and the valve prosthetic anchored to the ventricular muscle or to the reconstruction patch in a way that prevent leakage and pseudoaneurysm development beneath the prosthesis. For prosthetic mitral valve endocarditis, a new prosthetic mitral valve, mechanical or tissue, is acceptable again, unless there is a risk of intracranial bleeding, and this part is repeated in prosthetic. For double valve endocarditis, again, the same recommendation that's combined together. If aortic root and mitral annulus are preserved, so it's reasonable to implant mechanical or biologic valve based the choice of normal criteria. And if aortic root, again, destruction is there, or you need to replace the root, allograft or bioroot may be preferable. Infection destroying the intravalvular fibrosa requires reconstruction of this structure, and is preferable that surgeon taking on these cases master such as technique. So for right side infective endocarditis, the primary objective of surgery is to secure source control. And the valve repair is the first choice. Most surgeons prefer tissue valve if replacement is required. Excising the valve and leaving severe regurgitation is not advisable in patient with high pulmonary pressure. So the guidelines, they say that the primary objective of surgery for right side infective endocarditis is radical debridement of infected vegetations and foreign material. And tricuspid valve repair should be attempted whenever possible. So, should regular synthetic vascular graft or valveless allograft be used when the aorta must be replaced beyond the root? The regular synthetic vascular graft is the standard of choice, but a valveless or allograft is an alternative if an infected field for replacing the ascending aorta beyond the root. So the standard is the synthetic graft, but if it is infected, the alternative will be the valveless allograft. Should additional prosthesis and vascular graft not proved to be infected be removed and replaced? So if it is clearly infected, should be removed. If no obvious sign of infection, it's a matter of judgment. So inspection and removal of additional prosthesis and vascular graft, even not proved to be infected, should be considered, and it's reasonable if the causative organism is Staph aureus or fungal, provided that added difficulty and risk is not prohibited. When should a permanent pacemaker system be removed in patient undergoing surgery for infective endocarditis? If it is infected, should be removed, and if it is in the right side, affecting if infective endocarditis on the right side and affecting the tricuspid valve. So complete removal of pacemaker or defibrillator system, including all leads and the generator, is indicated as part of the early management plan and in patient with infective endocarditis and likely infection of the device or leads. But if it is no obvious infection, like here, complete removal of pacemaker, including all leads and generator, is reasonable in patient with right or left side infective endocarditis that caused by Staph aureus or fungi, even without evidence of device or lead infection. This is class 2A. But if the causative organism is any other organism, it will be the removal of the pacemaker and the whole system will be class 2B. Should patient with non-indication for pacemaker receive a pacemaker system with epicardial leads, and when undergoing operation for active infective endocarditis, epicardial leads are less likely to become infected. So at the time of surgery for infective endocarditis, implantation of a new pacemaker system with epicardial leads may be considered when the patient is pacer dependent. Are there any safety concerns regarding the use of mechanical valve in patients with infective endocarditis? Anticoagulation adds complexity to post-operative management. So mechanical valve should be avoided in patients with infective endocarditis with an evidence of intracranial bleeding or large brain infarcts, and in patient who is very sick and anticipated to have prolonged post-operative course. Is there any rule for local antimicrobial or antiseptic during surgery for infective endocarditis? Normal saline irrigation is integral for valve surgery, and no evidence of benefit from local antiseptic or antimicrobials. So after completed debridement, generous irrigation of surgical field with a normal saline is recommended as class 1. How should infected area be drained? Draining of infected areas is a fundamental surgical principle for managing infection. So whenever feasible, leaving infected areas open to the circulation or pericardium is optimal from the standpoint of treating the infection. How should operative spacement be handled? Pathological examination looking for inflammation, new vascularization, and organism is the gold standard for infective endocarditis. So Operative specimen should be secured for examination by pathologist to determine the presence of organism and the inflammatory activity. And the operative specimen should be also used for microbiologic and molecular testing to identify or confirm the pathogens and their sensitivity to antimicrobial therapy.
معلش سلطان.
ايوه.
اللي قبل كيف يعني keeping the surgical site opened؟ اللي قبلها أيوه.
If feasible, that and not the surgical site. If you have infected pocket and it's not through the annulus, or it will not cause like any like paravalvular leak or regurgitation. So leaving it open to the circulation or pericardium is optimal if feasible. But techniques capable, but if you can keep it even to the pericardium.
Oh, okay, thanks.
So, what is the role of molecular testing for PCR in identifying the pathogens? PCR is helpful in case of blood and tissue culture negative infective endocarditis. So whenever there is clinical suspicion of infective endocarditis and doubt about the causative organism, molecular testing can be useful to identify and confirm the pathogens or causative organism in the operative specimen. Post-surgical management. What post-operative antimicrobial treatment is required for, and how long should the patient be treated? In active infective endocarditis, the standard duration for IV antimicrobial is 6 weeks. Longer duration for more invasive or infections or persistent presence of hardware and satellite infection like osteomyelitis. So when preoperative culture and organism sensitivity are known, so the antimicrobial regimen and duration of the treatment are reconsidered and decided upon the preoperative culture. And after surgery for active infective endocarditis, the standard duration of post-operative intravenous antimicrobial treatment is 6 weeks, counted from the day of surgery. But regimen and duration may be modified and adjusted beyond on the organism, depending on the organism and its sensitivity to antimicrobial treatment response and pathology. For fungal infective endocarditis, lifelong oral suppressive therapy is reasonable. What is the need for follow-up and additional screening for infectious foci or that could cause recurrent of infection or recurrent infective endocarditis? The risk of relapse is in the first 6 months. The risk increase with drug abusers and follow-up needed by infectious disease specialists for the first 6 months and cardiologists with echo and psychosocial therapists to treat addiction. So primary infectious focus and microorganism portal of entry must be treated during or just after infective endocarditis episode, including follow-up and screening for underlying infectious foci and morbidities. In infective endocarditis, caused by Streptococcus galeolyticus, its indication for colonoscopy within a reasonable time after operation. Patient with a history of injection drug use should be treated for their addiction. And after surgery for infective endocarditis, eradication of the pathogens is essential and should be verified by follow-up for 6 months with an infectious disease specialist. After valve surgery for infective endocarditis, cure of the infection should be documented by echo, and the patient should follow up with a cardiologist. What is the risk of relapse and recurrent infective endocarditis? The risk for recurrence is 1 to 3% per patient per year, and there is early phase relapse and long-term phase. So patients who have undergoing surgery for infective endocarditis should be informed about the increased risk of recurrent infective endocarditis and the need for prophylaxis. Now we'll go finally with some special consideration. Should surgical treatment be offered for injection drug users with infective endocarditis? The operative risk is not higher, but they have a greater probability of death in the year after operation. So normal indication for surgery are reasonable to apply on patients.
سلطان ما نسمع ترى. سلطان
في صوت يا جماعة ولا لا؟
أنا سمعتك عبد العزيز بس ما أسمع سلطان.
سلطان الصوت من عندك ينقطع، ممكن تشيك عليه.
الو
ايوه
ايوه سوري تسمعني الحين؟
تمام
تفضل.
من وين وقفنا؟ من هنا من الدراج ابيوزر.
اي صحيح.
I'll repeat from here. خلاص okay. Special consideration. So should surgical treatment be offered for injection drug users with infective endocarditis? Operative risk is not higher, but they have a greater probability of death in the year after operation. Normal indication for surgery is reasonable to apply to patients who are intravenous drug users, and decision-making must take the addiction into account, and management must include treatment of the addiction. Should surgical treatment be offered to patient with infective endocarditis and he's on dialysis? Dialysis patients are 10 to 18 times more likely to develop infective endocarditis. Operative risk is greater and long-term outcome worse. These patients classify the biologic implants faster. So normal indication for surgery are also reasonable to apply in patients on dialysis, but their additional comorbidities must be factored into their risk and outcome assessment. Patients with renal failure have shorter durability of bioprosthesis and allograft because of early calcification, and they may be considered in the choice of allograft or bioprosthetic versus mechanical valves. Should surgical treatment be offered to patients with infective endocarditis and liver cirrhosis? Liver cirrhosis is a risk factor for infective endocarditis. The operative risk is related to the severity of liver cirrhosis. So also again, normal indication for surgery are reasonable to apply in patients with liver cirrhosis, but their additional comorbidity must be factored into their risk and outcome assessment. Who should get antibiotic for prophylaxis for infective endocarditis? Ideally, patient with greater risk of infective endocarditis or adverse outcome from infective endocarditis, like patient with prosthetic valve and previous infective endocarditis and cyanotic congenital heart disease or congenital heart disease repaired with prosthetic material. So patient who have undergone surgery for infective endocarditis is a high risk group for recurrent infective endocarditis and should be recommended for infective endocarditis prophylaxis according to the guidelines. Finally, how should patient with remote infective endocarditis be managed? Like normal surgical indication can or should be applied. Normal indication for valve repair or replacement apply to a patient with head or remote infective endocarditis, but condition predisposing for infective endocarditis should be diagnosed and treated. Thank you.
Thank you.